Right, ladies and gents, then we're going to go on to our last online lecture. And this is actually a lecture that's a collaborative effort from 3 doctors from Madhwaleni Hospital. So Peter Schalnisch is the guy that's going to present, and it's regarding congenital heart disease prevalence, patterns and outcomes at a South African rural district hospital, a cross-sectional study. So we're looking quite forward to that one. I think that's going to be a good one. Thank you.
Good afternoon, everyone. Can you hear me? Hello, can everybody hear me?
Yes, Peter, thank you. We can hear you. You can go ahead.
Okay, cool. Thanks. Yeah, good afternoon. So my name is Peter Schalnisch. I'm a medical officer at Madhwaleni District Hospital. And I'm sorry for not being there. I had some family and work commitments that I couldn't get out of. I would have loved to have been there, but I'm thankful for post-COVID era and Zoom. So I'm going to be presenting on congenital heart disease, the frequency, patterns, and outcomes at a rural district hospital. I'm the principal investigator, and my co-investigators are Dr. Mahikweni, who's a pediatric cardiologist, Dr. Porter, who's a family physician, and Dr. Westwood, who's a medical officer also at Madhwaleni. I'm going to be starting off with a clinical case of a 2-month-old girl. She's HIV exposed. She was born term and previously well. On anthropometry, she plotted as a MAM, so she had moderate acute malnutrition, and she presented with a 1-month history of cough and fast breathing. She was assessed as a very severe pneumonia and admitted on IV antibiotics. Bloods were drawn, and she was for TB workup. She was seen the next day on the ward round, and a pansystolic murmur of 3 out of 6, grade 3 out of 6 was heard. A focused cardiac ultrasound was done, which showed a large ventricular septal defect and a dilated left ventricle. The diagnosis was changed to cardiac failure secondary to congenital heart disease, or CHD, and this was specifically a VSD. She was initiated on anti-failure treatment and then referred to the tertiary hospital a few days later for continuation of care. I'll be sharing what happened to her at the end of this talk. So contents, I'm going to be speaking about background information, the objectives and setting of the study, some methods, results, and then some take-home messages. So the background, SDG3 calls for the end of preventable deaths in newborns and children under 5 years of age. And the aim is for an under 5 mortality rate of less than 25 per 1,000 live births. Globally, congenital heart disease is a major problem with a global prevalence of 9.41 per 1,000 live births. And this makes it the most common congenital disorder. To put this into perspective, 1 in every 100 babies, approximately 1 in every 100 babies, is born with congenital heart disease. The mortality of congenital heart disease is also very significant, with it being the leading cause of infant mortality in many European countries. This despite the fact that 80% of congenital heart disease of children with congenital heart disease will live into adulthood if diagnosis is made promptly and the right treatment is initiated. High-income countries have reduced mortality rates up to about 50% in the last 10 to 20 years. And this is in stark comparison with low-income countries that have made very little gain in reducing congenital heart disease mortality. In South Africa and Africa as a whole, there is a general paucity of burden of disease data and prevalence data relating to congenital heart disease. But in South Africa, we have noted that the under 5 mortality due to congenital disorders has risen. With congenital heart disease being the most common congenital disorder, it is likely that we are seeing a rise in mortality due to CHD. The current under 5 mortality rate in South Africa is between 37 to 40 per 1,000 live births, and it's remained relatively stagnant over the last 10 years. What this shows us is that emerging causes such as congenital disorders and congenital heart disease will need to be targeted if we are to reach SDG 3. But is congenital heart disease a rural health problem? Well, 43.3% of children in South Africa live in rural areas, and the burden of many child health issues falls most heavily on those in rural areas relating to access to care, access to sort of specialist child health doctors, and social determinants of health. What about congenital heart disease? Is it any different? And this is a question we ask ourselves, especially when one considers the global prevalence of congenital heart disease. We know that the pediatric cardiac service in South Africa is overburdened, and getting children to see a specialist pediatric cardiologist for formal diagnosis is often challenging, especially where the index of suspicion may be a bit lower. So what did we do? We started incorporating a focused cardiac ultrasound into our diagnostic assessment. A focused cardiac ultrasound, or FOCUS, alternative terms of bedside ultrasound or POCUS, point of care ultrasound, is a focused examination of the cardiovascular system performed by a physician using ultrasound as an adjunct to the physical examination. And this is the machine that you can see that we use. On the bottom left is the pediatric cardiac probe. And what we did is we basically started learning how to do a focused cardiac ultrasound. This was done in conjunction with a pediatric cardiologist and through spending time in his clinic. A focus is not currently recommended as a screening tool for CHD, but it is a useful, it's widely used as an adjunct in the diagnostic assessment, and especially so in resource-limited settings. We see throughout Africa where focused cardiac ultrasounds are used in the screening and diagnosis of rheumatic heart disease, sometimes by nurses in the community. And yeah, what I want to be sharing today is some of our findings since we've started using focused cardiac ultrasound. So the objective of our study, the primary aim is to describe the frequency and patterns of CHD among pediatric ward admissions. And the secondary aims is to determine the proportion of children with CHD misdiagnosed as a non-cardiac condition on first assessment, and to describe the use of a focus in the diagnostic assessment. The setting is Madweleni Hospital, which is a 220-bed district hospital in rural Eastern Cape. If anyone knows where Hole in the Wall is, it's pretty close to there. And it's a hospital that provides primary care services to the Mbashe sub-district. This is just a picture of what it looks like around here. And as you can see, access to care and access to health services, you can see that it must be challenging for everybody that lives around here. But it's a beautiful place. If you're ever here, I would definitely recommend you come past and say hi. So methods, what did we do? We conducted a retrospective, descriptive cross-sectional file review on children with a final diagnosis of CHD. Our inclusion criteria were children 0 to 13 years old admitted to the pediatric ward with a final diagnosis of CHD. And we used a definition that was in keeping with global norms and standards of CHD. Of note, this excluded patients with patent ductus arteriosus of prematurity and small ASDs. These children could be all new presentations of undiagnosed CHD or children with previously diagnosed CHD but who were born at Madweleni Hospital. Admissions also had to be within the study period, which was from the 1st of January 2020 to end of December 2021, so over 2 years. We identified our cases by conducting a search of all hospital-based clinical records. And this included all admissions, referral, death registers, ultrasound records. And then once each case was identified, we retrieved the file. All cases of congenital heart disease received diagnostic verification by the pediatric cardiologist at our referral hospital, and we received ethical clearance through Walter Sisulu University. The results. So over the study, over the 2 years, we found 11 cases of congenital heart disease, 8 cases of previously undiagnosed congenital heart disease, and 3 cases of previously diagnosed CHD. Are you still there? Yes, can you hear me?
Peter, sorry, man. Yeah, we broke up. Our connection is a bit distorted on this side. Can you move about? Sorry.
Yes, cool. Are you seeing the results slide?
That's right, we are. Sorry.
Okay. I'm not sure where you broke up, but I think I'm just going to go into the results.
Thank you. We can start at the methods. That's where we last listened to what you're saying.
Okay, let me just carry on here then. So the inclusion criteria were children 0 to 13 years old admitted to the pediatric ward with a final diagnosis of structural CHD. And the definition of CHD was in keeping with global norms and standards. And I've noted it excluded patients that had patent ductus arteriosus of prematurity and an atrial septal defect and small atrial septal defects. These could be children with any new presentation of previously undiagnosed CHD. And in children with previously diagnosed CHD, they had to have been born at Madwaleni Hospital for them to be included. Admissions also had to be within the study period, which was 1st of January 2020 to 31st of December 2021, so over 2 years. We identified our cases by conducting a search of all hospital-based clinical records, and this included admission registers, discharge, referral, ultrasound libraries, and then once each case was identified, we retrieved the relevant files. All cases of CHD received a diagnostic verification by the pediatric cardiologist, and we received ethical clearance through Walter Sisulu University. So these are the results. Over the 2 years, we found 11 cases of congenital heart disease, 8 cases of previously undiagnosed, and three cases of previously diagnosed congenital heart disease. In the table, you can see the frequency per age group. And of note is that in the infant age group, 0 to 1 years, we found 9 cases of CHD to give a frequency of 1.32% of admissions. In under 5s, there were 10 cases, this is total under 5s, to give a frequency of 0.76%. And among total pediatric ward admissions, the frequency was 0.64%. This equates to roughly 1 in 75 infant admissions having congenital heart disease at a primary care facility. If we looked at the frequency of congenital heart disease among LRTI admissions, there were 5 children who were admitted as LRTIs that ended up having congenital heart disease. And if we looked at the total number of LRTI admissions, which was 151, we could see that the frequency of CHD among LRTI admissions was 3.3%. This equated to 1 in 30 children being admitted that had an LRTI, admitted as an LRTI, had a final diagnosis of CHD. If we try to calculate the extrapolated birth prevalence of CHD, so this wasn't a prevalence study, we're not trying to determine the prevalence of CHD in our community, but we found a extrapolated birth prevalence of 3.71 per 1,000 live births. And if you remember, the global prevalence is 9.4 per 1,000 live births. It is likely that what we're seeing in hospital among our admissions is only the tip of the iceberg of the burden of CHD in the community. Baseline demographics, the median age of presentation was 5 months. There was a slight male predominance. Around half had a weight for age below the -2 Z-score, and 25% of cases were associated with a genetic condition, of which the most common one was trisomy 21. So how did these children present, and how did we use the focused cardiac ultrasound? As we can see here, in terms of the admission diagnosis, 75% of cases of newly diagnosed CHD were initially admitted as a non-cardiac condition, and this most commonly as acute respiratory tract infection. We used the focus in the diagnostic assessment in 87% of cases, and we were able to confirm CHD in 62% of cases of newly diagnosed CHD. Of note, the focused cardiac ultrasound, when it was done, was never normal. So we never had a diagnosis of CHD with a completely normal focused cardiac ultrasound. The take-home messages for me from this is, number 1, CHD is being misdiagnosed as acute respiratory tract infections. And number 2, a focus can allow for early and remote diagnosis at a district hospital level in 62% of cases of CHD. The final diagnosis and outcomes. So this is just the pattern of CHD that we saw. And the most common lesion was a ventricular septal defect. And this was just over half of all of our cases. This is in keeping also with global prevalence data, which we know that a VSD is the most common form of congenital heart disease. Of note is that all of these lesions are volume overloading lesions. So we didn't see any obstructive lesions such as aortic stenosis or pulmonary stenosis or coarctation of aorta. And we also didn't see any cyanotic lesions. I think what this probably tells us is that it may be related to our diagnostic capabilities, and it may also be related to access to care for children, because generally children with cyanotic lesions are a lot sicker and die soon after birth. The outcomes, 27% of cases ended up dying, and there was one case that ended up getting corrective cardiac surgery. And these are just some cool images. You can see in the bottom left and the left-hand side, that's an AVSD, an atrioventricular septal defect. In the top right, you can see a muscular VSD. I don't know if my pointer is showing, but over here on the left is an AVSD. Here is a small muscular ventricular septal defect that you can see over here. And this is a large membranous VSD that had bidirectional shunting. Take-home messages. Number one, congenital heart disease is not rare, and it will present at primary care level. It is often misdiagnosed as LRTIs, and the focus can allow for early and remote diagnosis of CHD. Mortality due to CHD is high, and it's likely underestimated currently in rural areas of South Africa. And we need to be advocates for children that are currently disadvantaged because of where they live. A child born outside Maduleni Hospital with congenital heart disease is disadvantaged when compared to someone that's born outside of Red Cross Hospital, for example, and that shouldn't be the case. Just of note is that common childhood conditions such as LRTIs, malnutrition, diarrheal disease are still priority. And I'm not saying that we need to start focusing all our efforts on CHD, but CHD is definitely an emerging and probably underestimated contributor to child mortality and morbidity. So where do we start? Number one, awareness, probably the most important thing. We need to be aware of the prevalence of CHD. Number two, if the child presents with respiratory symptoms, listen to the heart. All of our cases actually had murmurs that we initially missed. Build a relationship with your local referral hospital. What's worked really well for us is we have a very good relationship with a pediatric cardiologist, and we are able to WhatsApp images and videos of cardiac ultrasounds. And this helps us to diagnose children early and helps us to learn. Put a probe on it. Start looking at children's hearts. It sounds scary, it sounds intimidating, but you have to start somewhere, and I've got some really cool resources to share. And it's not only that you'll pick up congenital heart disease, we notice there's acquired cardiac conditions in children as well. Upskill yourself and those around you, and then reinforce referral at community level in terms of clinics and CHWs of children with persisting symptoms and growth failure. So what happened to our 2-month-old girl with a VSD? So this is a recent photo of her. She ended up being in and out of hospital with us for a couple of months with recurrent LRTIs, recurrent heart failure, and failure to thrive. And we eventually managed to get her sent across to Red Cross Hospital in Cape Town, where she got her VSD repaired. And she's now alive, well, and thriving. Thank you. If you've got any questions, comments, or would like to learn more, would like some resource to learn from, please contact me. Here's my cell phone number and email address. None of us are experts, but we're all kind of learning this thing together. And yeah, I'll be very keen to chat to anybody. And these are my references. Thank you.
Thank you, Peter. All right, guys, that was quite a mouthful, and I have to take my hat off to these guys. Very ambitious, and it's actually a win-win for rural health. And more of these type of studies should be done in South Africa, really. So these folks have really come through, and well done. Any questions from the gallery? Someone that wants to ask Peter a question?
Sorry, I had a question about the increasing prevalence of, I think he said congenital disease in South Africa. So I had like a question, if like during the research it came up why there is an increased prevalence. Is it like a reflection of increased research, or like increased reporting, or like increased like epigenetics, environmental factors? Like what, like if it came up at all? I'm just interested. It's not anything like, yeah.
Yeah. So I'm not actually sure. The information that I got that from was from an article in the SAMJ where they basically they were looking at under 5 mortality. I can share it if anybody's interested, but they didn't go into detail as to what the reasons for the increasing in contribution of congenital disorders to under 5 mortality. So I don't know, it probably, as we get better with pneumonia and malnutrition and diarrheal disease, the contribution to other disorders will get more in terms of under 5 mortality. But so that might be a reason, and then probably also due to diagnosis and reporting. But I can't actually comment on the reason. Like I said, that was from an SAMJ article. Yeah, that I can share if anyone wants to know.
Hi, Peter. Yeah, sorry, Billy Breitmach here. I'm pediatric St. George. Yeah, I agree. I think that is definitely playing a part, that as you have better care and less deaths of the other diseases, that this care, you're going to identify more and more cardiac lesions. I mean, when we started here and did outreach, the amount of work we've been sending to Red Cross has been incredible, especially in the first few years. It's now tapered off, but I mean, Red Cross come to us twice a year, where they would see do echoes on 100 kids. And it's a screening test where they would then probably refer. Because I mean, the question I have on echoes, and it's amazing what they do, sorry, but it's really amazing. The thing that is sometimes holding us back is this: if you do an echo, it's quite a definitive examination, and if you say it's normal, that becomes a concern. And this is one of the things that has held us back in going this route. And I've got my hat off for you. It's incredible what you've done. That's just our concern.
Yeah. Hi, Dr. Breitenbach. Yeah. So I must say, I think one thing that I tell everybody around here is that I can never, with an ultrasound here at Madhuleni, we can never say there's no congenital heart disease. And I think that's why the American Society of, in 2019, there was a consensus statement by the European, I don't know, big people in Europe, and they basically said that it's not a screening tool for CHD. So I'm very aware of our limitations. I think the argument that we have here is that it's either what we offer or offer nothing, especially when it's a screen, when the index of suspicion is low. And we have kind of a flow diagram where what we do here is, even if our echo is normal, if we still suspect congenital heart disease based on our clinical findings, the patient still needs to go across to the pediatric cardiologist for a formal review. So I think it's more, the use is more in remote diagnosis one, and the time to diagnosis can be reduced and management can be instituted quicker. We also actually looked at, and I haven't included this is going to be in a bigger study, but acquired heart disease as well. And we saw a lot of, we've actually seen a fair amount of cardiomyopathies as well that were initially missed. So yeah, but anyway, it's a very good point. I mean, yeah, we aren't cardiologists doing these scans, so we can never say that it's normal. We can just say if there is something. Oh.
Normal, then it was almost certainly normal. Whereas if we didn't see anything, it just meant we didn't see anything. But if we did see something and we were looking in the right place and trying to do it right, then it was probably significant. And so I think it's sometimes just about knowing your own ability and then realizing that, if you see something, it's significant. If you don't see something, that might just be your skill. And so kind of going humbly into that space, but also going boldly into that space, because it's scary when you don't really know anything and you're trying to learn, but it's also, for most of us, the only way to learn skills like that. I mean, there are courses and things, but it's practicing. The more you practice, the luckier you get.
Very valid point. Yes. Thank you. Well, thank you, Peter. We really appreciate that. Was awesome. Thank you for attending. Right, guys, any last questions, any comments?
So I can't let the opportunity go by. Peter, as Herman speaking, to just commend Peter for what he's done. I had the privilege of working with Peter last year, and I can't tell you how many times we, after a handover meeting, we would walk to the tennis court for ultimate frisbee and having a good time. And Peter would dodge to the left, going back to the pediatric ward, finding a patient to echo. I can't tell you how many adults Peter, although that's not his, favorite population, adults Peter echoed as well, and just kept trying and trying and trying until he's, really skilled at finding congenital heart diseases and going the extra mile for the kids. So I just want to really commend Peter. It's been hard work, but it's been amazing from my perspective, seeing Peter just keep going and trying time after time. So well done, Peter.
Thanks, Wolfie. I think you're a bit biased there, but thank you.
Thank you, everyone, for that. Right, Peter, take care. Thank you so much for speaking to us. Right, guys, that's the end of this session class on clinical practice. Thank you for attending. I think it was a good one.
I don't know how to get this thing. How do I? I think I don't know how to get started. Oh, because you were